helps him tick along on a day-to-day basis. But I'll give him the floor. Yeah, it's all Dr. Alex.
Awesome. Thanks, Alex. Well, great to be here, guys. Session 4. Today we're going to be talking about undoing the damage. Yeah, so let's launch right into it. So just ground rules. Remember, guys, questions, I love them as long as they're coming from a person, right? So if you're going to ask a question, turn your video on, por favor, and let's do it. So this is week 4, undoing the damage. So we're going to do a little bit of a deep dive into tooth replacement options, partials, bridges, and implants, which are near and dear to my heart. So we go back a little bit, right? Let's review a little bit of anatomy. And we need to know this like the back of our hands. So the TMJ, temporomandibular joint, right? It is where these two bones, the temporal bone and the mandible, articulate. All right. The big hole back there, that's your ear canal. So for a little bit of landmarks, your ear would be right above this area here. Now, if we zoom in, now we start asking questions, folks. So I'm going to start calling on names, and the people with your videos on, please be ready. Mariana, I like your sweater. We'll start with you. All right. So number 1 here, what is the structure that is identified? Number 1.
Was that the ear thing? No.
No. So the ear canal is back here. It's this hole here. So this structure that is between the mandible and the skull bone, the temporal bone, that sort of lubricates and allows these two guys to roll smoothly. Who wants to chime in with the answer?
Is it the mandibular fossa?
No. No, this is the disc. All right, this is our articular disc. So that's that squishy, slippery layer that helps those two pieces of bone glide comfortably over each other. All right, so number 2 up here, we're pointing to this big muscle that covers the side of our head. Who remembers what that's called?
Is that the temporalis muscle?
Is it the zygoma?
Exactly, temporalis muscle. Very good. Now, structure number 3 here. So if we have the fist and hand cupped, it's the cupped hand part. What do we call that piece of bone? Camille.
You mean the one that's on top, number 3?
Yep.
Would that be like the temporal bone?
So more specifically, what do we call that area? That's the fossa. I don't know who said it earlier, but that's what we call the fossa, the glenoid fossa specifically. All right. So what is this? This is this whole bone we call the mandible, right? The lower jaw, structure number 4. But in particular, this little notch of the bone that touches the disc, what is that part called?
Is that the condyle?
Perfect. Who was that?
Me, Eileen.
Eileen. Yes, exactly. The condyle. Perfect. And now what about number 5? Here we're also pointing to a muscle. This is the other one of the dynamic duo of closing and clenching the jaw. So we have the temporalis on the side of the head, and we have this other one down here. Who wants to chime in with that one?
Is that the masseter?
Exactly. That's the masseter. Good. So these 5 structures are like the primary movers and shakers when it comes to the TMJ, right? We have the 2 bones, which is the condyle and the fossa, the disc in between, and the 2 major muscles that control it all, the temporalis up here and the masseter. Right. Cool. So now we're going to get a little philosophical here. All right, let's all put on our ancient Greek caps and talk about what is our purpose. All right, we're not going to go down like our purposes as individuals or whatever, but our purpose as dentists. Like, why are we doing what we do, right? Why do you guys want to do this? Anyone want to share what they feel like their purpose in dentistry is? Okay.
To help improve people's life quality, their quality of life.
Yeah, man. Like, you basically took the words right out of my mouth. The toys are fun, right? I hope you guys all love working with your hands and like having cool new toys and cool gadgets and stuff like that, because we are like the kings of toys and hardware and lasers, and like we all go goo over all those fun stuff, right? And they're just like, they permeate every single aspect of what we do every day. So that part is really cool. Making a good living, certainly part of the overall equation for most of us, right? We want some security in our job. Like, we're going to commit a lot of time and money to earn the right to practice dentistry and medicine. So being compensated for that factors in, right? Maybe we have a higher, sense of calling, where we have a responsibility to our patients to be the guardians of their oral well-being. And yeah, that too, right? But ultimately, like, what we do is we're quality of life doctors, right? Like Alex hit the nail on the head. Like, we help, like, what do we use our mouths for? Right? We use it to eat. We use it to talk. We use it to convey emotion, smile, right? And we use it to be intimate. So like, it is all like central pillars of living a good life, right? So we are the ones that, so Guardians of the Galaxy style, right? Like, have that as our calling, as our mission. Now, number one thing that gets in the way of that good quality of life is edentialism, right? And edentialism is the term that we use for missing teeth. Dent means tooth. Edentulous means not having teeth. And you can be either partially edentulous, right? You're missing a few teeth, or fully edentulous, where you don't have a tooth in your head. Okay? So let's look at a few stats. You'll like this part, Alex. So by age 17, statistically, 7% of people have lost at least one permanent tooth, not including wisdom teeth. Okay? So by the age of 17, all of our adult teeth have erupted, usually except for the wisdom teeth. And a little tidbit for you guys. So we all have, how many molars do we have in each quadrant? So on my top right, how many molars do I have if I had my wisdom teeth?
3.
3, right? So we have first, second, and third molars. We call first molars 6-year molars because they come in roughly at the age of 6. Call second molars 12-year molars, third molars wisdom teeth are 18-year molars, right? And those are roughly the ages that they erupt. So by the age of 17, we mostly have up to our second molars. Now, 7% of people, that's a lot, right? That's like 1 in 8? 1 in 12-ish, right? People have lost one permanent tooth. Let's fast forward to 35 to 44. People have lost an average of 12 teeth, including their wisdom teeth, right? So take away the wisdom teeth, which many people just routinely have removed. That means the average 35 to 44-year-old has lost 8 teeth because of some sort of pathology, right? Decay, periodontal disease, they broke them because they're stressed out of their minds. That's a lot. That is a lot. Now, go to 65, 25% of people have lost all of their teeth. That is really sobering, right, guys? Like, not having any of your teeth, that's a bad place to be. So, and from losing 12 to losing all 28 that we're accounting for there's a lot of teeth that need to be lost, right? So there are a lot of people in this range that have half their teeth, right? That have a third of their teeth. They just have like the front teeth left. Now, thankfully, as a profession, we are getting better at saving natural teeth, right? It used to be that our parents and certainly our grandparents' generation would go to the dentist with a toothache and they would walk out with some gauze shoved in their mouth because they had a tooth removed, right? Like nowadays, we've gotten way better at saving teeth, doing root canals, minimally invasive treatments, intercepting things early so that they don't have to get to the point where they have another tooth taken out, right? But what's happened is, although we're getting better at saving natural teeth, population has grown so much that there is more demand for options to replace teeth than there's ever been before, because the growth in population is making up for that improvement in us saving teeth. So let's talk about what happens when we lose a tooth. Because some people feel like, all right, I got a tooth taken out. I have another 27, right? Like, why does it matter? And less people feel that way. Certainly folks in our you see what I did there? I included myself in y'all's demographic. That's kind of wishful thinking. But younger folks don't have that lackadaisical approach to losing teeth by and large. But a lot of people still, it's surprising to me how much you'll tell people, hey, like, we're not going to be able to save this. And they're like, oh, okay. It's like, dude, like, stuff happens, right? You're having a piece of your body amputated, removed, right? Like, it's a big deal. But let's talk about what happens when we do take teeth out. What are the consequences? Number one, resorption. This is a term that we need to know well, and we need to know what happens really, really well. So the way I explain it to my patients is taking a tooth out is kind of like wiggling a fence post out of sand. Now you got a fence post sticking up, kind of wiggle it around, pull it up. Now you got a hole down there, right? Wiggle the fence post, take it out, and you've got a hole. If you don't do anything with the hole, you just sort of leave the hole, the sand around that hole falls into the hole and lowers the overall level of the sand. That makes sense? So it just sort of like collapses in on itself. And this is what we see with the bone. So we take the tooth out, the bone starts filling in from the bottom, right? So this is the base of the socket right here. Bone starts filling in slowly in that area when we take the tooth out. But what happens is the bone up here breaks down almost immediately, right? So you'll have a scenario where the tip of the root was, you'll have some bone, but overall it's much lower than it was originally. It's lower and it's narrower. So the bone is just sort of collapsing in on itself when we take a tooth out, okay? And that process is much faster the first year. We can expect to lose about 25% of the bone in the jaw in the first year after taking a tooth out. 25% bone loss in 1 year. The second year, it drops down to around 12, 13%, and then it levels off somewhere around 5% a year for the rest of your life, okay? Until it becomes like a shriveled up little prune version of what it once was that is useless to you as the dentist and to the patient to function with, to consider replacement options and all sorts of things. So really, we never want to be here, right? Another thing that happens is tooth drifting. So what keeps teeth in place is other teeth, right? So if we were to take out, this looks like the lower left first molar, and just leave the hole, the teeth around the hole sort of drift into that hole. So the back tooth, the distal tooth, the tooth distal to the space is going to drift mesially, right, towards the front, towards the midline. And then the opposing teeth are going to supra-erupt. The process of eruption, like when your teeth poked through your gums, we call that eruption, right? That process of eruption is constantly there. And the only thing preventing it is that it butts up against another tooth. That's cool, right? Like our teeth are constantly erupting, aside from the fact that teeth provide a doorstop. So if you take that doorstop out, that top tooth keeps drifting down. And it happens from the bottom up too. And sometimes it's so dramatic that when the patient closes their mouth, like this tooth will have stayed back here, or maybe they didn't even have it. But when they close their mouth, now this tooth touches the gums down here. Like it totally collapses the space and just keeps drifting downward. And what provides that doorstop becomes the gums on the other side. We also have increased stress on the teeth that are left, right? Like if you're designed to operate with 28, maybe 32 teeth, like what happens when you drop down to 20? Right? Like those other teeth have to pick up some of the slack, right? They're going to do some of that heavy lifting. So what happens to the teeth that are left? Right? They start breaking down more. They wear out more. They crack, right? We also have bite collapse. We talked about this with the TMJ lecture, where when we wear our teeth out, right, the tip of the nose and the tip of the chin get closer together. That makes us look old prematurely, right? So losing teeth, especially our back teeth, increases that collapse of the bite, makes us look older faster than we should. So what do we do to avoid all of those horrible consequences? Right? And we were talking like super technical, like dental folk consequences, right? We didn't even discuss like the impact on the patient's function, day-to-day chewing ability, and confidence, right? And it's not just affecting your confidence if you're missing number 9, right? And you're missing one of your front teeth, but what if you go to like a restaurant with people and you want to eat something, but you've got missing teeth in the back and you know you can't chew your food as well? Like that affects your confidence too, right? So quality of life, right? It's all about maintaining patients' quality of life or improving it where we can. So let's talk about how, right, all of our preventive measures didn't quite do the trick and we lost some teeth. So now we need to discuss replacement options, right? I call them flavors. So replacement teeth come in 2 basic flavors. You have fixed and you have removable. And all of the different options fall into one of those 2 camps, right? Fixed means we put it in and it stays in until we take it out, okay? There is no way to undo fixed usually without like completely redesigning the whole thing. So here we're talking about things like bridges and implants. Have removable, which is placed and removed by the patient routinely, right? Usually every day. Put it on, take it off. And here's where we have dentures and partials. All right. So let's talk about what these all are. We have the tested, tried, and true denture. The unsexiest of the dental tooth replacement options. Everyone has probably seen one of these. Very few people other than dental folk know how they work. right? We're going to talk a little bit about them. So here we have an upper denture, and here we have a lower denture, right? How do we tell them apart? The lower denture has a space open for your tongue, okay? Now, upper dentures, whoever designed the first upper denture was super, super clever, right? Upper dentures actually create a suction cup effect in our mouth. Because of how they are designed, they extend to the back to cover all of your hard palate, and they come up into the vestibule, or where the cheek kind of meets the gums, that turn there, we call that the vestibule. And in doing that, it creates, it's a suction cup. It goes, like you can actually hear when a patient puts it on, it creates suction in their mouth. And then when they're designed well, like a patient will have a tough time taking it out, right? They have to like pull on it and break that suction to get that top denture out. The bottom denture, on the other hand, is a nightmare. We call them ballerinas, tops. They've got all sorts of colloquialism type names because it's always just dancing around in the patient's mouth, right? No matter how well designed a bottom denture is, just the fact there's a lot of moving parts in the floor of the mouth, right? You've got the tongue, and that's lifting the floor of the mouth constantly. So they do not have a whole lot of stability, okay? And we call that stability retention. And it's an important term for dental folk. And we can have retention with any of the tooth replacement options, right? It can be with a removable appliance, with a denture. It can be with your orthodontic retainer, right? If that retainer, you put it on, it's falling out of your mouth, it has no retention. It's doing nothing, right? With a retainer, those of you who've had them, you know it needs to be tight, right? So upper denture, phenomenal, right? It's a chunk of plastic in your mouth that's replacing all of your teeth. It works, but it's like having a wooden leg, right? Gets you around, but we need to temper expectations. The lower denture, on the other hand, horrific. So you will frequently see patients in our parents, grandparents generation that will have full upper dentures and then just a couple of teeth on the bottom that they have fought tooth and nail, no pun intended, to save to give that bottom denture a little bit of retention and stability. All right, so one of the things that we do with those ballerinas is we lock them down, right? And we do that with implants. And when we do that, we call that denture an overdenture, right? Overdenture, all it means is it's a full denture that snaps into place on some implants. And when we do that, now we're counteracting the tongue and the floor of the mouth and all of that, and we actually have a really stable prosthesis, right? Patients function really, really well with overdentures. And sometimes we do overdentures with 2, 3, 4 implants. It depends. Clearly, the more the better, right? For various reasons. One, it's going to be more stable still, right? If you have 4 implants versus 2 implants, right? With 2 implants, you create kind of like a seesaw effect on those 2 implants, right? So if like the patient bites on those front teeth, bites into like an apple or something, it's going to seesaw down a little bit and lift from the back a little bit, right? And if they chew on the back, it's going to seesaw up a little bit, right? So you're relying on the implants plus the soft tissue, the gums, to give you stability everywhere. Now, if you have 4 implants, now you have a table, right? So you're going to have a really stable sort of platform to function on, right? Not to mention that, hey, sometimes implants fail. And if you have 4, you're down to 3, you can still function with 3, right? You still have a stool. It's going to be relatively stable. If you have 2 implants and you're down to 1 implant, now you're kind of up a creek, right? Now, partial dentures. Now, if I only had a nickel for every time I've heard a patient call this a bridge, I would have a bunch of nickels. A partial denture is just that. It is a removable denture, just partway there, right? So we have selected teeth that are missing on the denture. So here this patient has, looks like maybe a missing molar and a premolar, and back here we're missing all of the molars, all right? Fine. Partial denture works great in a situation like this, right? Because the partial denture uses little hooks, we call those clasps, to latch on to the teeth that are still left, and it's pretty stable that way. Now, what side do you think is going to be more stable? The patient's left or the patient's right in this scenario here? That's right. The left.
Right.
The left.
So the left. And why is that? It's because we have a terminal tooth here. All right, we have a tooth at the very end of the partial, giving it an anchor. All right, so you see here the partial goes all the way back. It replaces the last tooth in the arch. So this partial here is always going to have a tendency to kind of like raise up a little bit. Whereas this side here is going to be really pretty comfortable for the patient. Now, this picture here is showing you guys partials. We have different ways of making them. They used to historically be all metal partial with just acrylic teeth on them. More and more, we now make flexible acrylic partials. So you can really just kind of like pinch them, and they're much more comfortable. They're thinner than the old partials are, and they're all like gum colored. So we actually use custom acrylic shades to match to the patient's gum color, so that when they put it on, now you're not seeing those clasps, right? It all just sort of like blends in and provides a much more aesthetic result. This is what the metal ones look like. I don't think I've done a single one in private practice. We had to do a few of them in dental school, and then in private practice, folks just really much prefer the full flexible acrylic ones. And I can't say that I blame them. I mean, these metal clasps are I mean, they work, right? But as far as aesthetics go, maybe not the best. And partial like this, it actually works pretty good because no one would see this. But if we're talking about replacing upper back teeth, that means you end up having like metal hooks on teeth that show when you smile. So it's great. They work. They actually last longer than the flexible ones do on average. They just have the really big drawback that we need to have the metal hooks, and we usually have to cut dimples into teeth for the metal ones. They're called rest seats. It's a really nice euphemism. But you're literally like drilling and removing enamel so that a part of that metal framework can fit into the tooth and gain support on the tooth with it. I mean, everyone, like different doctors like to do things different ways. I don't like cutting into teeth unless we absolutely have to. So that covered our removable options. All right, let's talk about fixed options. So these are the ones that we put in and they don't come out unless we take them out. Number one, we have a bridge, right? So if it's removable, it's a partial denture. All right. The technical name is removable partial denture. This is where it gets a little bit tricky because the technical name for a bridge is a fixed partial denture. But people call these guys dentures and partials, and they'll call the removable one a bridge all the time. Just throwing terms around all the time. They'll be like, yeah, absolutely, doc. My previous doctor made me a bridge. See, here it is. No. So when we talk a bridge, it is something that is glued in place. It's cemented in place, right? And it's got a couple of terms here that we need to be aware of. The teeth. So what a bridge is really a crown on a tooth, right? Which is kind of like a football helmet made of porcelain. Another crown and a floating tooth in between. So this is the scenario. We're looking to replace this tooth here. We have two normal healthy teeth here that we had to prepare for crowns, right? Meaning reduce tooth structure all the way around. And then this whole structure that we call the bridge gets cemented in place onto these two teeth. Now we call the crowns abutments, right? This whole sort of complex is an abutment. So this is the abutment tooth, and this is the abutment crown. And then we call the floating tooth a pontic. For those of you who speak Spanish, pontic, Latin derivation, puente, right? It's a bridge. So a bridge is a phenomenal option to replace missing teeth. It has certain limitations, certain drawbacks. Number one, it can only be so long, right? We can't like have, 6 teeth missing and then do a bridge on one tooth and one tooth in front, right? Because what ends up happening is that the teeth, the abutments, right? The teeth that are the support for that bridge get overstressed because now they're not working for 2 teeth. They're working for themselves plus the 6 that you replaced on the bridge, right? All right? We're asking way too much of those teeth. So as a general rule of thumb, we need to have as many abutments as we have missing teeth. Okay? So it has certain limitations. We can't make them indefinitely long. The other limitation that bridges have, potential downside, is that we have to cut down teeth, right? We have to prepare teeth. And if these teeth were perfectly healthy, right? Didn't have a filling or a scratch in them. My personal position is that I don't even offer a bridge as an option to patients if they would be a candidate for a partial or an implant, right? Because I believe that compromising that other tooth structure in the long run puts our patients at a disadvantage, okay? Now, the other downside is that this area here will continue to experience resorption for the life of the patient. All right, that resorption happens when we're not asking anything of the bone, right? The bone is just sitting there and the body's really bright and says, all right, like you're not serving any purpose. You're not holding a tooth in place. You're not holding an implant in place. Let's just get rid of you. Like you're dead space, right? So that resorption just keeps happening and happening and happening. And this patient, you can cement this bridge on here in 2020, 2021, and they show up 2026 and they're gonna have a big old gap between this pontic and the gums. And it's because the gums have continued to drop down from that resorption, right?
I have a question.
Yeah.
Could that cause a lot of like inflammation or any type of like disease if it reabsorbs and then bacteria gets into it in between?
In between into like the bridge?
Yeah.
So you're probably not going to be at any more risk for like decay or infection or anything like that. What you are going to be at an increased risk for periodontal disease, right? Here is basically the bone in the back of this tooth here, right? And the bone in the front of this tooth here. So if we're losing bone here, it is indirectly affecting our abutments too, right? So we keep losing bone. So these teeth have less support in that area. And we have a bridge there now. So those teeth, instead of working for just one tooth, they're working for 1.5 teeth-ish, right? So it's just overloading the system more. You can see how it would just sort of lead to issues there. So I see where you're coming from with like the infection question, not necessarily, but it still has an impact on the overall area.
Okay, thank you.
Yeah. Oh, any other questions about bridges? You know, we really aren't getting into any materials here, right? Like we can make bridges out of metal. We can make bridges out of porcelain. We have different options, but just basic overall concepts, it all applies the same way. All right, so let's talk implants now.
I have a
Yeah, what's
question.
up?
You said that they're a candidate for implants, and what else? That they don't need a bridge. Usually when the teeth are healthy.
Or a partial. You know, we have some other way of you know, replacing the tooth in a way that is acceptable to the patient.
Okay.
I have a question. So how do you counteract that constant resorption of the bone? Do you just keep making bridges every once in a while when they keep like wearing down?
When you keep getting the gap?
Yeah.
That's one option. Really, the only way we have of halting that process is demanding something of the bone, and we're gonna talk about it in just a second because that's implants. It is the only way that we can keep bone levels where they were before, because it's the only way that we can replace the root of the tooth, right? So let's talk about that a little bit. Good question.
I have another question. Is that because the bone isn't stimulated?
Yeah, exactly.
Okay.
He serves no purpose. He's useless. Just a couch potato lying around. And our bodies are like, that doesn't fly here. All right, so implants. When the man upstairs makes teeth, it's all one sweet little piece, very well-designed little structure. When we make teeth, it's 3 pieces, all right? We have the implant body or fixture, right? That's the screw that goes in the jawbone. We have a connector called an abutment, and then we have a crown that goes over top. Now, I love history. I love all sorts of history, including dental history. So I want to take you guys on a little timeline of implantology. So 2500 BC, so 4,500 years ago, roughly, in ancient Egypt, they would use gold wire to ligate teeth and stabilize them and replace missing teeth. Check that out. Right, these 2 teeth are missing, right? The roots are broken off. They drilled holes in it and created a prosthesis and then tied it to the teeth next door. And I'll tell you what, that probably worked pretty well because gold is bacteriostatic, right? So although it's going to create nooks and crannies for bacteria to get in, it's naturally going to repel and kill the bacteria. So who knows how long this lasted, but it could have worked. And this is 4,500 years ago. So fast forward 2,000 years, now we're 2,500 years ago. The Etruscans, which like northern Italy sort of area today, created bridges using gold foil. So what they would do is these 2 teeth here are pontics, right? And they would create this metal structure made out of gold that they would slide onto the teeth next door. And they kind of got replacement teeth and a grill at the same time. So it was like they were to have fashion sense. Oh, I think I lost you guys. Are you back?
We're back.
Yes. You just froze for a second.
Okay. Got it. Okay. So 600 AD, right? So this is 600 years after Christ, roughly 1,400 years ago. This is one of the coolest things I've ever seen. The ancient Mayan made literally dental implants out of shells, right? And they carved them, they cut them into like lower incisor shapes and wedged it in the bone, right? So in some ways they were even more advanced than us, because now they made theirs out of one piece. Like, we need 3. Like they were doing all right. And guys, like, this actually worked. Like, there's some evidence of osseointegration, of like the bone locking in these pieces of shell. And like sterile technique, right? Saline, right? What is that? Soap? Like, they didn't even have soap. They were just cutting seashells with like poop encrusted tools and like jamming it in someone's jaw, and it took, right? Like, it actually worked. Crazy. Fast forward another 1,200 years. So now we're in the 1800s. We start experimenting a lot with implants, different types of metal. People would like extract teeth and shove a little rod of a different metal in the hole and just see what happened when it all healed up. And like, there's a reason they call it practice, right? Like, even still today, to some extent, like, we're sort of seeing what works best. And fast forward to like the 1900s, really trying a lot of different shapes and designs of implants and all sorts of different crazy things. Here, this is probably from the 1950s, 60s. We have 3 different kinds of dental implants here. On the bottom left and right, we have what are called blade implants. Yeah, I see Alex shaking his head. It's like, this is so gnarly. It's like, yeah, like, you would never be able to explain this to a patient and like have them accept treatment, right? Like, this is just too bizarre. But in any case, these blade implants were literally like a razor blade, right? And they would just do a flap, move the gums out of the way, drill a trench in the bone, and then slide that blade in, and then stitch the gums back up. And eventually the bone sort of like healed in between these areas here and like locked that blade in place. And it had this peg sticking out from the blade through the gums that you would attach something to. This down, I have no idea what this is. The trident of death, the spike of evil. I don't even know how you put that in the jaw, like in such a way that isn't whatever. This one up here is a little less barbaric, but still really kind of crazy. So this implant here, this implant went into the bone, what we call an endosseous implant. This doesn't. This is a supraosseous implant. So what they would do here is they would cut the gums, move them out of the way, expose the bone, expose the jawbone. They would take an impression of the jawbone. So if you guys have worked at an office or have had your impressions taken, right, like the goop in the mouth, right? They would do that, but with like the gums out of the way. So they're taking an impression of the bone. They would send that impression to a lab and they would make a model out of that bone. And then they would cast this structure that would just sort of like sit on top of the bone. Kind of like a lower complete denture sits on the gum tissue. Well, this was kind of like a framework of that would sit on top of the bone. So they would again cut the gums open. They would sit that little piece of metal on the bone and they would stitch the gums back up. And then they had all these pegs sticking out from the gums that they could attach things to. So a whole lot of experimentation of how we do what we do and what techniques and what metals. And folks, this isn't by any means a settled business, right? There are different designs of implants today, different materials, different metals, different techniques. So we're still just evolving the space, right? But this is today's implant, right? This is what most of us think of when we think about a dental implant. A fancy screw in the bone with a tooth attached. So how do we go about selecting patients, right? We know we weren't able to save the tooth, we lost the tooth. Now we have to replace it. And we've talked about options and we've decided an implant's the best option. How do we decide how to select patients for us to place our implants in, right? Like what things do we need to be cognizant of when we're recommending this treatment? Well, we need to know PMH or past medical history, right? We need to know how healthy the patient is, right? Like if you're a super diabetic, uncontrolled diabetic, if you cut your finger, you're so diabetic that your finger won't heal for 6 months, right? Like you are not the kind of patient that should be having an implant done, right? Like you should be minimizing any sort of dental treatment that is invasive in the least at all, because you don't heal well, right? So things like that we need to be aware of. We need to be aware of social factors, right? Like, are you a raging alcoholic? Or do you smoke? Right? We've talked in previous lectures, smoking is an issue, right? Because it has nicotine. And nicotine stops blood flow. And when we stop blood flow, we prevent healing, right? So if you do a procedure on someone in the mouth and they go out and they're so stressed out from the procedure that they smoke a half a pack, like now they are eliminating the healing period right after the surgery. What do you think is going to happen? Right? Like what chance of success do we have at all? Not great. Okay. We also need to know local factors. And when we talk about local factors, we're talking about local factors in the mouth, like the site of the surgery, the site of the implant. So local factors are, how much bone do you have? Right? Do you have a nice healthy like ridge of bone where you can put a screw in there and it's going to have plenty of bone around it? It's good. Or do you have a teeny tiny little like resorbed little micro ridge? Like how are you ever going to get an implant in there and have it be stable? Right? Like an implant is a lot like putting an anchor in the wall to hang a picture. If you've got a nice thick beefy wall, you can put your anchor in there and you can hang off that anchor. Right? If you've got a dinky little cardboard wall, right, you put your nail in and the weight of the nail itself kind of like drags, makes a little bigger hole in the wall, you can't hang anything on that, right? So we want a nice, thick, hard wall to put our anchor in. So all of these factors affect our prognosis. So is the prognosis good or is it bad? If the prognosis is bad, we deter patients from procedures, right? Sometimes we outright refuse to do them, right? If the reasons aren't right. Or we very clearly explain what the prognosis is, what the risks are, what the potential outcomes are, and what that's going to mean to them, right? And we get what's called informed consent. Right? We always do informed consent, but the conversation gets real when the prognosis isn't favorable, right? So implants come in two basic flavors too. We have bone level implants. Now bone level implants are placed just below the height of the bone. And we have tissue level implants. Tissue level implants are placed just at the level of the gums, right? So you have your bone and then you have your gums on top. Bone level implants go to here. Tissue level implants go up here. They still have the same basic three components. Right? You still have the fixture, you still have the connector, which is the abutment, and you still have the crown. It's just the implants span more or less, all right? And this too is a big subject of discussion in implant dentistry, which is better where and when and why, right? Like you've got experts on both sides, like advocating and preaching their dogma. Yeah. What we do know is that implants have an average success of about 98%. Even in unfavorable circumstances, right? So you have maybe not an uncontrolled, like horrible diabetic, but mild diabetes, even like mild smoking drops that success percentage down from like 98 to like 92-ish. So still like not bad, right? Think back to that Mayan seashell, right? No sterile technique, no nothing. Jammed it in there and it took. So we can accommodate for a lot. The planning process is fun. So nowadays we use CTs to treatment plan implants, right? And the CT is an X-ray that shows us 3 dimensions, right? So we have height, we have width, and we have depth. So we know exactly how big that ridge is for us to put our implant, all right? So here we just have different views, and we're actually able to, in implant planning softwares, see what the crown is going to look like, right? We can design the crown, the ultimate restoration that's going to be attached to that implant. We can put it digitally in place and then decide, all right, so the best place for the implant to go to hold this crown in the proper position is here. All right, well, if I put it there, do I have enough bone all the way around to really lock it in and keep it safe? Right? Sometimes we need to alter the position of the implant a little bit depending on how much bone we have. And sometimes we have to say, all right, we just have to add more bone. Right? So it all depends, and it all depends on how comfortable the practitioner is with all of those different steps, right? So step 1 is a plan, right? Step 2 is the osteotomy. That is a fancy name for a hole in the bone, right? So osteotomy means drilling a hole in your jawbone. Patients take much better to osteotomy, right? When you say, all right, well, we're going to get the osteotomy started now. It's like, ooh, okay, this is legit, right? Much better than, all right, Mrs. Jones, open up. We're going to start drilling a hole in your bone. But in any case, that osteotomy, that hole in the bone, we accomplish with a series of drills, right? And here we have Glidewell Direct. To be perfectly honest with you guys, I've never personally worked with Glidewell Direct, but it's a lab like for their implants. It's a lab that I've worked with in the past, and they had a great schematic of their drills for you guys to see. So we go from a teeny tiny little hole to the right size hole in steps. Okay, so we always start with what's called a pilot hole. So anyone who's hung a big frame, right, you've probably started with a tiny hole first, got the hole started, right? So you got it lined up exactly where you want it on the wall, and then you make the hole a little bit bigger. Same thing with the osteotomy, all right? So we open up the hole, right, shape the bone, and now we have our placement. So we put the screw in. So here we osteotomy, implant, we put it in, we screw it in, really like a screw. All right. So we have the implant in. Now we have to restore the implant. Right. So this is after the healing phase happened, usually around 4 to 6 months after. It's a term called osseointegration, meaning the bone around the implant has locked it in place. It grew and matured. Okay. So now we're ready for our restoration. Now we're ready for that abutment and crown. So what do? We usually place some sort of attachment onto the implant called a scan body. We scan it, right? Just like we would for Invisalign or a crown or anything else, right? We basically take a 3D video of that area. And this is what our lab uses to design that abutment and crown. And we have the delivery phase. So this is our implant. This is, what do you guys think this is? Is this a tissue level or a bone level implant?
Bone level?
Tissue level?
It's a tissue level. So the implant goes up here and then curves inward here. So a bone level implant would end right here. This is spanning the gum tissue that has been removed on this diagram, but the gums would be up here. Then we have our abutment that gets screwed into the implant body, and then we have our crown that gets cemented on top. And we call the process of putting that in the patient's head the delivery or the insertion. Then we have maintenance, right? Some people think that implants are bulletproof. They're not, right? They require really, really excellent hygiene and maintenance. They need to be periodically evaluated by a dentist, make sure that we're not losing any bone around that implant, and then we're keeping it clean. They're very susceptible to inflammation. Right? So the same way we can lose natural teeth with periodontitis, we can lose implants with peri-implantitis. All right, so we need to stay on top of them. Just a quick note on grafting and socket preservation. So if we have to take a tooth out, we have no choice. We have that big hole left in the bone. How do we prevent that ridge resorption, that first 25% bone loss in the first year? We do a bone graft. So we wiggled our fence post out, right? We got a big hole in the sand. We're gonna fill that hole in the sand with more sand. And in the case of the mouth, it's a bone graft. So we have the hole, we fill the hole with bone, and it's just like a powdered particulate. We cover that with a membrane and we stitch it closed. And now with that bone graft there, that collapse of the bone on top doesn't happen. So here we have a scenario with a bone graft, and here we have one without. And you guys can see how we call this the buccal plate of the bone has just totally collapsed inward. If you're going to put an implant in here, what do? You have no bone, right? We would have to cut the gums here, rebuild this bone to have enough bone to then put an implant in. We could have prevented all of that by doing a bone graft when we did the extraction. You guys saw this case, I think, for the TMJ, cracked tooth, extraction, immediate implant placement. So here we have, you can see some of that membrane right here. And the stitches, this, we're actually delivering this crown next week. Yeah, healed up great. I will maybe someday give you guys an update picture on that. And last thing that I'm going to touch on is hybrid dentures. Okay, so hybrid means a combination of removable and fixed. These have gotten really, really popular over the last 10, 15 years. So what happens here is it's basically a denture, right? That instead of snapping on to the implants so that the patient can snap it off and like brush everything and clean everything, it's screwed into the implants. So the way it works is the patient comes in hopefully every 3 months for us to unscrew, right? Take all these screws out, remove the denture, clean it for them, clean the implants, and then put everything back together. Now, I am personally not a huge fan of the hybrid denture because it's kind of like communism. It sounds great in theory, but when you factor in human nature, sometimes the expected outcome ain't what you hoped it'd be. So folks have usually lost teeth because maybe their maintenance and their hygiene wasn't the best. Now let's tack on this big structure with implants and screws and dentures that stays in there all the time. And there's a space, right? There's actually a pretty big space. And this is what a hybrid denture looks like. And this is a conventional full upper denture. Now, there's a space here, and the patient needs to, anyone who's ever had braces, right, gets how difficult it is to clean in between structures in the mouth, right? So you have all of these gaps here and nooks and crannies and stuff that need to be kept super, super clean. And most patients just don't have either the diligence and desire or the dexterity, right? We're talking about older people that maybe don't have the ability to really get in there and clean things to maintain this the way it should. And then not to mention that you put this in there and they feel great. So they think they don't have to ever come back to the dentist. And it's like, what are you talking about? Come every 3 months. Like, I feel awesome. No, doesn't quite work that way. So if the patient has something they can snap off at night, they can brush, right, the implants, brush their teeth, put the denture in their cleaning solution. It tends to facilitate that process for them. All right. But hybrid dentures can be great. We can make them out of either plastic or porcelain. And they definitely, you know, provide a much, much more stable option over a removable denture and bottom. So quick announcement, we are wrapping up the applications for DMD Bound's March session at the beginning of March. So we don't do first come, first served. We do a full like application period. And then 1 month before classes start, the board sits down, reviews applications, and we make phone calls for interviews. So there's still time if you guys are interested. DMD Bound is where you can find that application. And if you guys have any questions for me, feel free to reach out, Dr. Alex at dmdbound.com. And we're on the socials and all of that as well. So any questions about any of the 4 sessions? Now we got to all the questions already throughout. All right, I got a question for y'all. Is there anything in today's replacement lecture that you wanted to learn about that you didn't hear? All right.
Maybe like some of the common complications of each.
Ah, that's really good. Yeah. Okay. So we kind of talked about the complications with the bridge, right? Got ongoing bone loss. You end up with the space between the gums and the pontic. You may trap some food there. It may also affect the abutments, right? With how much bone level they have, keeping them in place.
And maybe also
complications with the dentures.
Sorry.
No, go ahead.
I wanted to say maybe also like what the quality of life for the patient is, like for each type.
Yeah. So, I mean, how to answer that one, right? Like, we are really adaptable to our present circumstances, and folks get used to all sorts of different things. Like, people have gotten used to upper and lower dentures, and they've functioned. People have gotten used to nothing, right? Like just gumming their food to death, and they function, right? Now, there's an old story in my family, like way back in the old country, where some random family member had full dentures and he never wore them, but he ate chicharrones, and that's like the gold standard of you know, eating hard foods. If you can plow through one of those with whatever you got, you're doing okay. And he did it with nothing. So one could say that his quality of life was probably okay. He did not quite mind. But without a doubt, like the more we are replicating what we're replacing, the better the quality of life, right? The less complications comes from it. And right now, the best we've got is dental implants. It'll reach the point probably in late my career, maybe y'all's career, where we start doing really like fancy, weird things like regenerating teeth, right? Like biologic replacements. That's coming, folks. Like that's coming at some point. You know, broke a tooth, it rotted out of your head. All right, let's get some stem cells and science, right? And then grow you a new tooth. So, but for right now, implants are the way to go for best quality of life.
I have a quick question for the hybrid dentures.
Mm-hmm.
So when you put them, you will still be having a lot of the reabsorption. You said it, the resorption.
Very good.
Because
So,
uh,
right. So let's go here. Let's take a look at this picture, right? So you are going to continue to have some resorption back here. Right. Now, it doesn't really bear any sort of impact on the function of this, right? Because we've got 5 implants here, and we usually put them like right around here. And then we have a couple of teeth that just hang off the back side of all that. So from here to here, all of this bone here is protected, right? Because we're demanding something out of that bone. It serves a purpose. But back here, yeah, you're absolutely right. You're probably gonna have some more resorption. Now we can really cut down on how much if when we took those teeth out, we grafted, right? Because you eliminate that first 25 and then 12% bone loss. And you just sort of start with that 3 to 5% bone loss a year. That makes sense?
okay. Thank you.
I
Thank
have
you.
a question. Is there resorption with implants or just bridges?
So just bridges. So we get resorption when we don't give the bone a purpose. All right. A bone without purpose gets resorbed. That should be like a motivational poster or something. Right. So the way we demand something out of the bone is by putting an implant in. So neither dentures nor bridges are going to give us that.
Thank you.
Yeah.
There's a question in the chat.
There's a question in the chat now.
Yeah.
Alex, I need you on top of those, man.
It says,
What to tell you?
which implant is better, bone level or tissue level? Personally, which do you think is better and why?
Oh, hot topic. Hot topic. It depends on where in the mouth we're replacing it. It depends on the aesthetic requirements of the implant long term. They both have, in my opinion, they both have a place in modern implant practice. They'll have similar successes. The only difference between one and the other is that with a bone level implant, because you're starting off much lower, you get to control how, we call it the emergence of the implant. So let's see. So here, if you had a bone level implant, right, you're going to design and shape the abutment that gets screwed in there. So you can either make that really like narrow, coming straight up, or really flare it out. So it can either come straight up from the implant, or you can really like flare it out from the implant. And now you start controlling the aesthetics of the gum tissue, right? Because if you have an abutment that goes straight through the gums here, and then you need to make a big tooth on top, you end up with like this candy apple on a stick effect, right? Our teeth aren't shaped like that, right? Notice the emergence, the profile of this natural molar here, or this premolar. It sort of like goes up and then flares outward, right? It's got a very, very sleek curve to it, right? There's no hard line angles anywhere. So the bone level gives us a little bit more flexibility of how we transition from here upward, right? And for some areas of the mouth, this shape works perfectly fine. Like for premolars, tissue levels work great. For certain molars, tissue levels work great. For anything anterior, I would do a bone level implant because aesthetics are more important, right? They're more of a consideration. That was a fun question. That's a good question. Anything else, guys?
I have a question.
Okay.
I don't know if I just got a little confused because there were so many different like options, but there was an earlier slide you showed with, I think it was dentures, and since they had lower retention, like using implants to keep them like stable.
Mm-hmm.
What's the difference between those and then the hybrid ones we were talking about at the end?
So I'm going to really assume that your video just isn't working because I'm kind of getting a question from the Black Ether a little bit. But yeah, so the overdenture, which is the one that snaps on, is still sort of removable, right? Because the patient themselves is putting it on and taking it off. The hybrid gets screwed in place and the patient never takes it off. Like the only way that denture comes out is if a dentist unscrews it from the implants and removes it. So they can still both be dentures. It's just how they're attached is different.
Okay, because I had, when I first saw the implant ones, I thought, yeah, that answers my question. It's just when I first saw them, I thought it was only removable by the dentist. That's why. Thank you.
No, right. So good. So the overdenture back here, right? This guy
Gotcha.
here, this snaps in place, and the patient snaps it in. The patient snaps it out.
Oh, okay. I see. Thank you.
Mm-hmm.
I've got one question.
Yeah.
Outside of cost and like bone levels, are there any other reason? Is there any other reason why implants won't be the best option in almost every situation?
So we look at those local factors,
Mm-hmm.
right? We look at that past medical history. We look at those social factors, right? All of those things together have to formulate that decision for us. Without a doubt, if those other things are under control, I mean, implant is by far the best option, right? It's going to be the most comfortable. Again, it's the closest thing we got to a natural tooth, right? And none of these are replacements for teeth. And I always tell my patients, none of these options are a replacement for your teeth. It's a replacement for your missing teeth. Okay? So there's a really big difference there, right? We can never expect any of these things to be as good as the things that eons of evolution and or intelligent design created. Okay? So, but within that spectrum, implants are the closest thing we've got.
Awesome. Thank you.
Yeah. Cool, guys. Well, this has been a ton of fun for me. I hope you guys have enjoyed it. And yeah, if you guys have any questions, you guys know where to find me.
I have a question.
Yeah. Oh, okay. Sophia.
Sorry. This doesn't have anything to do with what you were talking about, but I was at work the other day, and this patient, like, her whole treatment, she had a bunch of things she had to get done, and her whole thing came out to, like, I don't know, like $20,000, but she couldn't afford any of it. So obviously, like, she couldn't get anything done, and that just makes me feel bad. Like we're here to help. Like, we're here trying to do this to, like, make people's smiles better. Like, I don't want to contradict, like, because I want to be a dentist, right? And it's, like, really good living, but, like, it's so expensive that you can't help somebody, you know what I mean? Like, how do you help them in that situation? Does that make sense?
Sure. And I mean, but I totally get where you're coming from. And you're coming from an empathic, caring point of view where we want everyone to have the best, right? But unfortunately, just the world doesn't work that way, right? And we replace teeth, and that's like a car, and some cars are a Honda Civic, and some cars are a Maserati, right? And they're gonna get the job done. And within those options, we do the best we can for patients, and sometimes that means we're gonna make them the best set of dentures we can, right? And it's gonna cost them $3,500 and not 25 grand or 35 grand, right? A big case where we're replacing all of the teeth with implants, I mean, that can be a $45,000 project, right? But the point is that for us to deliver that service to patients, like, we have had to invest not only our lives, but a significant percentage of our finances, right? And we take on a lot of risk too, folks. So it's a really sort of complex, it's just the system that we're in, you know, like there is no clean answer for the scenario that you're presenting. And it is valuable because it's something that we run into, right? Folks just can't afford the best option. So we want to always present them with good, better, and best, right? And if we just can't swing best, maybe better or good, right? And then we treat them, what we always want to do is treat them all with the same dignity and respect, right? Like their fundamental value as a human is unaltered by their ability to afford more or less sophisticated dental treatment, right? And within those parameters, we do the best we can. And we come up with creative financial solutions too, right? Like very, very, very few people. There was just an article that I was reading. The average US household could not cover an unexpected $500 expense. $500. That is like no dentistry. If you have anything at all significant going on in your mouth, $500 isn't even going to begin to cover it. Unless you are going to a free clinic or something like that, right? I'm talking specifically from the private practice standpoint, right? Where, how many of you, show of hands, how many of you want to go into private practice, want to own your own practice?
I don't know.
Okay. So of the videos that are on, the majority of you guys, right? So ultimately we're running a business when we do that, right? We're running a business and we are responsible not only to our patients, but we're responsible to our team members to provide them a good quality of life, right? If we're giving away the house for free, how are we going to pay our people? How are we going to invest in our people to have them grow as individuals, as professionals, right? How are we going to invest in ourselves to continue getting CE courses and pay for what are you guys expecting to graduate with as far as your loans go, right? 300 grand, 400 grand? Like, you guys have invested your life into that, right? So we do the best we can. We offer patients options. We provide them financial options, right? So if you can't cover that $3,500 for the upper and lower denture, Mrs. Jones, we have, payment arrangements, right? We work with financing companies that make it affordable, because it's not about that, what was it, a $20,000 treatment plan, right? Who the hell can pay, write a check for 20 grand? Here you go, doc. No one, right? Statistically, no one. Not no, but very few people. So, but if it's $350 a month, all right. Like, how much does a Civic cost? Right? A Civic is like 27 grand. Who could afford a Civic outright? No, but you can afford the $300 a month payment, right? So we work with people. And I'm sorry, but that's just the best I got.
No, that was good. I just saw that and she left super unmotivated and she had also been in a coma for 8 months before because she had gone in a car accident. So I was just feeling bad all everywhere. And I was just I want to help you, but I can't. I'm a student.
Yeah, no, I totally hear you. I totally hear you. And we actually in my practice, we call it the financial menu. We present finances the same way every single time. We have what it is and then what your options are, right? And those options are payment arrangements. They can be pay in full, whatever, pay as you go. And we just try and make it as affordable for people as we possibly can.
Yeah.
Because we also don't want to ever compromise the level that we're doing things at, right? If you start feeling bad about oh, I can't charge for my work because I feel bad for the patient that they're going to have to pay so much. Maybe I'll just use a little bit cheaper composite, right? And save a few bucks so that I can save the patient a few bucks. Is that doing anyone a service? Really, ultimately? Mm-hmm. I don't think so. So I want to use the best that I possibly can and charge people a fair price for the work that we're doing.
Yeah.
That allows me to take care of the team and the business and continue to invest in that, right? And have the time to do things like this with you guys, right? So yeah, I get it. We want to do the best for free, but
I know. Okay, thank you for
it's
answering
like
it.
communism.
Yeah, thank you.
Yeah, absolutely. All right, guys. Well, it's just about 1:30 here. It's been awesome. It's been an absolute pleasure to be with you guys these 4 weeks. And again, if you guys have any questions, y'all know where to find me. Dr. Alex at DMD Bound. Happy to answer any questions.
Thank you, Dr. Alex. These sessions have been incredible, super informative, and everything. Yeah, we really appreciate you, coming back to love the Golden Panthers, and yeah, wish you the best, and hopefully soon we'll be back. Maybe this semester, who knows? But yeah.
Yeah, we'll stay in touch, no doubt.
Thank you.
Thank
Thank you so much.
All right, guys. My
Bye.
pleasure.
Thank you.
Bye.
Bye. Have a good day.